What's up, everybody? Today I'm talking to Dr. Sara Brungardt to discuss OCD. She's the CEO and founder of Calm OCD, and today we're planning to discuss what OCD is, what it looks like, and exactly what to do about it. Dr. Brungardt, how are you?
I'm good. Thanks for having me on today.
I am so excited to talk to you today about OCD, what it is, how it works. Before we do that, can you introduce yourself, just talk about who you are, what you do, and kind of why you do it?
Sure. My name is Dr. Sara Brungardt, and I am the owner of a practice called Calm OCD. We have physical locations in Scottsdale, Arizona, Tucson, Arizona, and our newest location is in Sandy, Utah. And then we provide telehealth, I think in about 15 states now. So we offer virtual options and in person. Our kind of passion, we treat all levels of OCD, but our true passion is really around treating severe and extreme presentations of OCD.
Wow. One of the things that I thought was really interesting about OCD as I was reading up on it was the number of people, the underdiagnosis issue. I didn't know that this was such an extreme case. I know some people in my personal life that struggle with it. And I think there's it's complicated because, as is the case with a lot of stuff, pop psych can kind of get in the way and meddle with it. Like we've all had people be like, it's my OCD that I did X, Y, or Z, or I fixed my zipper or whatever it is. So I think the first question that I would really love to talk to you about is what is OCD and what isn't OCD, right?
Yes, and I'm glad you brought this up. So most recently, they say 1 in 40 individuals likely have OCD. But like you said, you know several people that likely meet that diagnosis. And the more and more that I talk with people and people ask what I do, they typically say either, oh, I have OCD, or so-and-so has OCD. And it's so incredibly common. So one of our passions at our practice is people getting that correct diagnosis. And so with that correct diagnosis, you can get evidence-based care, whether that be with the therapy that we do at our clinic, or with the medication piece that you guys do, or a combination of the two. So one of the things I'm so passionate about is providing the correct information about what OCD is and what it is not. I was at yoga, a couple months ago, and the yoga teacher said, I need everybody to line up their mats because, I'm sorry, this is my OCD. And I just kind of cringe, a little bit at something like that, because OCD truly is a debilitating brain condition. And people have to understand that the suffering that can happen through this condition is very different than somebody that just has a preference, somebody that has a preference for having the yoga mats lined up correctly, rather than debilitating anxiety as a result. And so you're exactly right.
Yeah. So I've talked about it with other providers on this podcast before, but I think it's a point worth belaboring. The term disorder and what that means in relation to it's a significant impact to your way of life. So lots of people have intrusive thoughts. I do. I feel like everybody does.
Yeah.
What's the difference between an intrusive thought and someone who should consider seeking guidance?
Yes, I love this question. So I don't have OCD in particular, but I do experience intrusive thoughts as well. The difference is somebody that doesn't have OCD, their brain is able to experience an intrusive thought and then disregard it. They don't have an extreme emotional response, or the intensity and pain associated with that intrusive thought just isn't there. They're able to disregard and able to move on. An example I always tell people is I was at the grocery store one day and somebody passed in front of me. My foot was on the brake and an older gentleman passed in front of me, and my brain said, oh my gosh, what if you put your foot on the brake or on the gas and you hit him?
Right.
So my brain was like, oh, that's ridiculous. And then I parked my car and I went on, got my food, and that was it. Somebody with OCD what their brain does is it attaches meaning to that thought. What type of a person would you be if you had that thought? Why did you have that thought? Oh my gosh, did that really happen? Did you? What? So constant mental rumination. Another thing I'm really passionate about is people understanding that compulsions, the behavior people are doing after they receive an intrusive thought or fear or worry, the compulsions most primarily are coming from a mental state. And so the constant rumination, constant problem solving would likely have occurred if that example happened to somebody that had OCD. They would, did I hit that individual? What type of a person am I? I need to circle and check. I need to call my significant other and seek reassurance. I need to watch the news to see if I really did hit someone. And so the fight or flight is activated when they receive an intrusive thought. So that amygdala is on fire. And so when I explain to families, a lot of times if they have a child suffering from OCD, they're like, I don't get it. Why are they having this extreme response? And I'm reminding them, this is a brain condition. The circuits are misfiring and their brain is saying danger, danger, danger when danger isn't always present.
Right. So that brings me to my next question, which is, where does OCD come from? I know there's some genetic component, but it's not, what would you say? It's not predestining. And mental health and psychological disorders are really interesting because they vary into the degree of how much is external versus genetic or internally caused. Depression and some types of anxiety can be very externally caused by environment, right? And there's some debate as to whether or not that is depression and anxiety, right? If you're sad because someone passed away, that's more of the normal human life experience. But other conditions like ADHD do seem to be less so environmental and more internal, or at least the relationship seems to be less a rumination disorder of mood and more of a disorder of actual brain processing. So what causes OCD and like where does it fit in that? Yeah.
So typically at our clinic, we notice, and research also confirms, there's a strong genetic link. So it is not uncommon for us to end up seeing probably 50% of the family.
Wow.
And so sometimes they'll have their session at the same time, and one individual goes to that therapist and another individual goes to that therapist. So really, when I work with therapists on how to screen for OCD properly, it's really important to understand that family history. And because OCD is missed, not only do I need to know if mom or dad have anxiety symptoms, I need to know what that sounds like. What do we know about anxiety with mom? What do we know about anxiety with grandma and grandpa? What behaviors, do they kind of pique my interest a little bit? Because it's likely those older generations have not received that correct OCD diagnosis. And so when I press further on those questions, people will say, well, now that I remember my mom never drove on freeways, and or my dad would wipe down the grocery. And so they start talking about some of these behaviors that kind of pique my interest some. That, okay, maybe there is a line of some OCD behaviors. The most common misdiagnosis is people just think they have anxiety, or people have been diagnosed with generalized anxiety disorder. The differences with something like GAD, anxiety tends to be more free-floating, and it tends to dissipate after something occurs. So maybe I am anxious because I have to give a presentation at a conference. That anxiety dissipates after it's completed, right? Somebody with OCD, their brain tends to have major themes. So fear, I'm not going to be able to sleep tonight. Fear that something bad is going to happen. For kids, it may be a fear that an intruder is going to break into the house. Fear that I blurted out an obscenity or insult to somebody. So they're going to be having these major themes that no matter how hard they try to feel better about that fear, they're not getting relief. So no amount of rumination, no amount of seeking reassurance, no amount of tapping rituals, no amount of going back and checking gives them relief. And so that's the major difference I see. A lot of times people come in, maybe they're not ready for treatment, but they just want a diagnosis. Usually we can, within 60 minutes, we're able to provide a lot of clarity to what people have been struggling with for decades. I think the average length of time to receive a correct diagnosis is over a decade.
Wow.
In my experience, I've seen it much, much longer. I've worked with 60, 70, almost 80-year-olds receiving the diagnosis for the first time.
Wow. Does it, over a lifespan,
Great
does
question.
it come in waves? Does it alleviate? Is there a spike?
I love this question.
Yeah.
So we could talk for a few hours about this. My answer for everything in life tends to be it depends.
Yeah.
What I'm seeing is, so with a lot of mental health conditions, as the person gets older, the symptoms reduce. With OCD, it's typically the opposite.
Really?
One of the reasons is if you haven't done the training of how to essentially change some of the framework in your brain, you'll spend years reinforcing those circuits. And so you're going to be more symptomatic. You're going to have an increase in symptoms. So that's typically what I find. I see an increase a lot of times over puberty years. So we tend to get a lot of people in our clinic during puberty. Also see an increase during big life transitions. Periods of stress will activate those regions of the brain even more that create, maybe they've had OCD symptoms before, but maybe a move to college or a wedding or a marriage or a new job kind of creates this huge trigger that has looped them into doing compulsive behavior, therefore increasing symptoms.
So what does this look like neurologically? I'm a huge brain nerd.
Yeah. And like I said at the very beginning, people have to understand this is a brain condition.
Right.
This is not something that people choose. This is not a weird personality quirk. If we have time, we can talk about preference and more of what is like an OCPD type presentation. And I think I did a podcast on that too, where we talked more about that. So if you have time, please remind me to talk about that.
Yeah.
So if we look at it in the context of what's happening in the brain and the looping system, so we're going to look at the orbitofrontal cortex. That is the area that's kind of estimating threat. And so all of our brains have this function. Somebody with OCD, simply explained, have an overestimation of threat. So if there's a 1% chance or a less than 1% chance that something could occur, that brain is going to say, danger, 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 pay attention to me in this area of the brain. Okay. And so then we're also going to be looking at a part of the basal ganglia. And the basal ganglia is going to give us attention to whether we move forward, do we pull away, do we do something in repetition? What is our action, right? And then if we look at it from the thalamus point of view, that's attempting to create this loop. What ends up happening is, and what is so discouraging for OCD sufferers, it's not just a thought they're experiencing. They're having an extreme chemical response. So that fight or flight system, that amygdala that is on fire, is creating this looping system. The problem with that is you have an obsession, you have those what if scenarios that are happening in the cortex. But then if you are responding to those through compulsive behavior, compulsions are anything the individual does to eliminate the distress that the obsession causes. So if the person with OCD is doing compulsions, which everybody does, why wouldn't you? We listen to our brain every day. I listen to I try to, maybe not always. I try to listen to my brain of when I need to eat breakfast, when I need to sleep, when I need to do different things. It makes sense that people with OCD are listening to their brain and doing compulsive behavior because they truly, truly believe that there is an active threat. Those same regions of the brain are being activated in such a way that it is life or death. What is even harder about this is the majority of the time, rationally, logically, people know or suspect that what they're doing may not be reasonable for the situation. Sometimes with extreme OCD, the perception changes a little bit and people may genuinely feel they have to perform these things. But as somebody gets better, what they start to realize that their brain has a faulty alarm system. It's saying danger, danger, danger a lot more than the average person. I remember years ago, I was trying to explain this to a family, and the parents said, I just don't understand why she's having thoughts that we're going to poison her. Why would she choose to have that thought? And so it's a great learning tool and learning curve for me to explain. Nobody would ever choose to have that thought. The OCD brain is so creative and very fascinating. And anybody could have that brain, but her brain is saying there's a strong likelihood, or maybe even a little bit of a likelihood that this could happen. We need to always be cautious. We do not need to take any risks because of this.
Yeah. That kind of, it cuts into like a really interesting question of like neurophilosophy of like, where do thoughts come from? Because the default answer is like, well, they're yours. They come from you, but you don't build your thought, right? They just arrive and then you experience it. And so you're not the creator of thoughts, you're more the judge of a thought.
What do we do when we have that thought?
Right.
That is the most important piece. We get thousands and thousands of thoughts a day. If I truly believed every single thought that I have ever experienced, I would never have moved out of small town Kansas and came to Arizona only knowing one person. I would not have taken the risk and open up a business. If I truly listened to all the self-doubt and things that I experience, I would not be moving forward. And so what ends up happening with OCD is that belief system around that thought is built. And so if we believe truly every single thing that our brain is giving us, they're following it up with action. Action that's reinforcing the brain's idea that we must be in danger. So if I have a thought that something bad may happen and my brain says, okay, I have a thought, something bad may happen. Because of that, I'm going to avoid getting on the freeway. I'm going to avoid going to work. What that does is it reinforces the brain's idea that every single time I get a thought like this, I should listen and stop participating in life. So over time, people's world gets smaller and smaller and smaller, and people aren't taking risks at all because nothing is safe. Everything is fear-based because once we've reinforced that loop over and over, what happens is you're going to get more and more and more obsessions. Most commonly, when we have people go through our symptom checklist, they're suffering from so many different subtypes of OCD. It happens, but it would be rare that somebody comes in with one obsession or one subtype of OCD.
Right.
A lot of times they've maybe had different subtypes throughout childhood, and then it's moved into relationship OCD. Then I moved into the fear of vomiting. Then I moved into fear that they're going to go to hell. It's going to be morphing over time. Something that came to mind is that's one of the reasons that it's missed sometimes is some of the subtypes like fear of doing something wrong or fear of making a mistake. If that's not investigated, that may just look like anxiety when it actually ends up being an OCD diagnosis.
Right.
So some of those subtypes that look like just perfectionism or different things like that still have to be explored to see if there's an obsession and a compulsion component.
So that's interesting. It's the compulsion that really sort of separates out the disorder.
Yeah.
Is it very much similar then to anxiety in terms of presentation outside of that? That's sort of the defining characteristic, or how do those things relate?
Sure.
Like, there's a lot of chicken and the egg in mental health of like
Sure.
ADHD and depression, right? Are you sad because you can't focus, or can you not focus because
Yeah.
you're struggling?
Long answer, it depends, right?
Yep.
So if we talk about like, if we look at depression, for example, it would be rare for somebody to not have some level of mood impairment when they have OCD. Especially if we're talking about people that come to us for like an IOP level of care where they're doing 8, 12, 20 hours of compulsive behavior a day. How could you not be depressed? And so a lot of times what happens is we start treating that OCD and that mood will just improve on its own. So that kind of is what comes to mind if we talk about the depression piece. For how just kind of obsessions and compulsions operate, I tell people with OCD, and I don't mean this to be not insensitive, but you don't necessarily, we have to change how you think about OCD. You don't necessarily have an anxiety problem, you have a compulsion problem. Okay. The other thing that's different, and I won't say this, as an absolute rule, but one thing that's mainly unique with OCD is the different emotions that are present in addition to anxiety. So that would be a major difference as well. So when people have fears, most likely they're experiencing an element of anxiety. But what's not talked about is the crippling fear, disgust, shame, guilt, panic. Those are kind of the main ones that come to mind as a response from that obsession that then creates this desire, this sense of urgency to do a compulsion.
Hey, what's up guys? My name is Garrett, and this video was made possible by Redemption Psychiatry. We're a private practice located in Arizona focused on providing mental health services for those in need. If you or anyone else you know is struggling, please feel free to have them give us a call today. Thanks, and we'll get back to the video. I find how the brain works really interesting in relationship to logic. There's a great book, Thinking Fast and Slow, by Daniel Kahneman, which is, he's more of an economist, but it focuses on how the brain interacts and why we're all terrible at math and risk assessment, basically.
Ooh, yeah.
And yeah, one of the things he discusses is sort of logical fallacies and heuristics that affect us. I think a good shorthand is like, somebody might say, well, if I wear yellow shoes, there won't be any crocodiles. You may say, well, there's no crocodiles in Arizona. I know, it works really well. it's like, well, and that's where you get these feedback loops, right? Where, it's really outcome bias, right? Is the outcome doesn't necessarily correlate with the effectiveness of your logic. You can
what
get
that
lucky.
belief system is.
Right. You can get lucky and unlucky. And it's that gap that causes, so much of it seems like exactly what you're talking about.
Yes, I think that's a great example.
Works.
We're finding meaning where maybe meaning really isn't relevant here. Maybe I just had that weird thought that I was going to hit a sweet older gentleman when I was at the grocery store. Maybe that's all that I experienced.
Right.
Rather than, it doesn't mean that I'm a horrible person. It doesn't mean that I'm going to want to kill someone someday. It doesn't have all that extra meaning that my brain is actually assigning to it.
Yeah, and the anxiety component is really interesting because anxiety is strange, especially physiologically. It's actually very similar to excitement, right? Is in both situations, you're going to get sweaty palms, your heart rate's going to increase, blood's going to move away from your digestive tract, right? Because you're getting either pumped or horrified. Your body actually does the exact right. Your body will do the same thing, which is super cool. And it's reassuring because if you start to feel physiological symptoms, it's nice to know that that doesn't necessarily mean that I'm anxious and that I now need to be anxious, right?
That sense of urgency isn't a cue that I need to flee a situation.
Exactly.
A sense of urgency doesn't mean I need to wash my hands for the 10th time. That sense of urgency and that fear that's over me doesn't mean I actually need to listen to it.
Yeah, I'm trying to think of who said it. It was a really good quote, which was, in order to find gold, you're going to find dragons, right? Which is to say that in order to move forward in life, in order to attain things that you desire, you will experience struggle, conflict, and there's a lot of things that play into how we respond to that, genetically and environmentally, of whether or not we take that as good or bad. I'm curious in terms of OCD. I really want to talk to you about treatment. On our end, so as we work with medications, I think the first stop for a lot of providers is usually an SSRI, which is really interesting because serotonin is not the issue, but it does seem to alleviate and improve a lot of the symptoms. As I peeled through the research, it was incredibly interesting because it found that one of the studies I was looking at showed that people who engaged in CBT exposure therapy for OCD benefited a lot, but if they got on medication after that, the benefit was really minimal. But the inverse was not the case. People who started on medication and then went into therapy had really phenomenal effect. So I really want to talk about, especially as a specialist, what you do, why you do it, what you're seeing work, and just what all of that looks like.
Sure. And I think you brought up a good point. Like when people come to our office, sometimes they're at different stages. Sometimes they've been on different medication and maybe want to try the therapy with us. Sometimes they are scared of medication. It's very common for people with OCD to be very fearful of medication. So they may have a desire or think that it could be helpful. So treatment a lot of times can actually be helping them with exposures to get on medication that they're fearing. I would say a large percentage of our clients do the therapy with us and are on a medication. I see also when hormonal changes happen, I find the medication also helpful in conjunction with what we do as well. I agree. I can't speak a lot to the medication since I'm, not a,
That's
not
why
a,
I really want
not
to
a
learn
doctor,
about what you do.
But I will say high-level SSRIs need to definitely be in the therapeutic range for OCD. What is common is when people come to our office, a lot of times they've never even received their OCD diagnosis from their med provider.
Wow.
And they're on an SSRI, but it's a low dosage and it's not in the therapeutic range for what we need it to be for an OCD diagnosis. And so a lot of times we'll call those medication providers, let them know, we did an assessment. It really looks like an OCD diagnosis. What are your thoughts on, the medication piece? And so that can be an important collaboration to make sure we have that correct. And so that's crucial. With behavioral therapy, so if we're looking at a type of CBT, which is exposure response prevention, people have heard about it a lot at this point. There's kind of some traditional methods of exposure therapy, and kind of us newbies have some different models. I think in the past, there was a lot of emphasis on exposing somebody to something, and the goal was anxiety reduction. So we're getting your anxiety to spike and allowing your anxiety to reduce. And then we're tracking it and we're logging our anxiety levels. I don't tend to align with that model. I don't like to hyper focus on the anxiety level because I think it's keeping people attuned to how poorly they're feeling rather than more of a acceptance and commitment therapy lens where we're moving towards what people value in life. How can I feel all levels of anxiety? Embrace guilt, embrace shame, embrace this uncomfortable emotion, but still go ahead and live my life. And so if we're having people lean into the things that they're avoiding, that's typically where we start. The part I see go incorrectly with exposure therapy is you're teaching clients how to feel uncomfortable with the trigger. But what's missed is you have to also teach them how to not do compulsive behavior. So if you are having somebody exposed to something, but then the whole time they're doing mental compulsions, or that night they're doing mental compulsions, or the next day, and the therapist isn't setting them up to be successful in that, what we call response prevention, then it's reinforcing and actually making them sicker and making their symptoms increase. So the exposure is the important part, of course, but the most important part, the RP, the response prevention, resisting compulsions. So both of those things have to be present in order to do ERP. And so that's really, really crucial. One of the major things I'm passionate about is I don't think that we have to do these dramatic, intense fear factor type of exposures to trigger the brain. Being a human triggers the brain for anybody, but for OCD, just going about your life is going to trigger. So it's going to be much more impactful if I'm teaching people how to deal with what's going on here and going back and participating in life rather than, licking our shoes or something silly like that. Like, how can I get this person back functioning and not feeling, a victim of their OCD brain is far more impactful than doing some dramatic exposure, with a trash can or something.
Right. That's really amazing. So there's a huge difference between avoiding negative stimuli and managing negative stimuli. And this is, everybody knows this implicitly. So for example, like I'm lactose intolerant, and there's plenty of memes and jokes about lactose intolerant just eating dairy products anyways because they love it. And if you ask any person who's lactose intolerant, they'll tell you like, well, I'd like to do it. I would like to have pizza and drink milk and chocolate milk and this and that. I don't want to build a life where I avoid all of those things. I want to find a way to overcome it. And now there are like enzyme tablets and stuff. This is not a PSA to go, if you're lactose intolerant, just keep eating cheese until you fix it. I don't think that's good advice. But to the same with mental health, right? And especially with anxiety, you're not in control of anxiety peaks, right? You can't control if a specific prompt, whether it be rational or irrational, arrives, right? And rational prompts will arise, right? You're going to have a car accident, or a family might get into a car accident.
Life
right?
is hard.
Exactly. And so it's how do you withstand, not avoid?
And it really, I see a huge shift in, rather than let's do an exposure, focus on anxiety reduction. What's your anxiety level? Kind of those old school treatment approaches to this new one where it's how can I improve my relationship with uncomfortable emotion? How can I build confidence in myself in realizing that I can do hard things regardless of the emotion, regardless of the trigger, regardless of the obsession. That's what builds resilience. When we help people avoid their triggers and avoid participating in life, that's not helping their functioning. So when we work with parents and they've helped their child avoid doing hard things, that is creating this dynamic that long term is going to create a lot of potential struggles for the entire family. So when we see kids, even with adults, we're working with that family system because they have to learn how they can't accommodate their loved one's anxiety. If somebody feels anxious, that's okay. If somebody feels uncomfortable, if somebody feels panic, that's okay. How are we going to move through that and no longer avoid that?
Right. Yeah, it's so inspirational. One of the reasons I love doing this podcast is there's so many things that are true in treatment for different disorders that are also applicable for everyday life, right?
Yeah.
And I think what I'm pulling out of what you're saying in part for people who don't necessarily have OCD is courage isn't the absence of fear, it's the spite of fear, right? It's doing it in spite. And to the same as you deal with anxiety, it's not the reduction, it's doing it in spite, which is so cool. I also love how you're talking about family systems and treating family systems. It's so important. One of the most exciting developments in mental health, I think, over the past decade or two has been the movement towards holistic care and avoiding sort of a hyperfixated, tunnel-visioned treatment mentality. One of the things that I want to discuss with you as well is I want to go back to OCPD.
Oh, yes.
So I think that this is what a lot less people have heard about. I don't think this gets into the common sphere as much, and I think it's a really important
We could do a part
distinction.
2 on this.
Yes, so please talk to me about what this is. And yeah.
So really within the past couple years, it's kind of been my newfound passion for helping people get the correct diagnosis, understanding it, and understanding what treatment could look like. So 1 in 5 people with OCD actually also meets the criteria for something called OCPD, Obsessive-Compulsive Personality Disorder. With that personality profile, a lot of times it is about preference. And so if we're talking a little bit about kind of what people perceive as OCD and not, OCPD, there is a strong preference. With that population, they tend to be really high achieving, perfectionistic, very driven folks. And it's almost like perfectionism on steroids. And I can catch this in kids, kind of that personality profile. So we can start treating that now. You know, this is the kid that's self-harming because they got a B on an exam. This is the kid that can't stand losing at a game and so refuses to talk to their family for a week. Like really these extreme reactions to daily life and in this realm of perfectionism and really this desire and a lot of times expecting things to go a certain way. And so these people sometimes are very dedicated to their jobs. They like to control the outcomes. They do not want uncertainty. I mean, nobody likes uncertainty, but with this, there's this element of control. If I can work so hard, if I can control the outcome, then there's nothing to really worry about. There's nothing to be uncertain about. So they have a very specific way of doing things. That could be putting dishes in the dishwasher a certain way, redoing how their partner is doing chores in the house, asking their partner not to do that so they can do it instead. They will constantly be giving their children feedback of ways they could improve athletic performance or schoolwork. Just a lot of that environmental effect within the family unit I see. And so significant others and kids tend to be highly anxious because they're anticipating what may happen or what may be said from the individual struggling with OCPD.
So what does treatment, how do you treat that?
So the most common mistake I see is with other OCD specialists is not catching the OCPD profile and being able to see the difference between the OCD profile and the OCPD profile. So if you don't see the difference and you're treating it all like OCD and all like exposure, it's likely that the person with OCPD is not going to be receptive to the feedback. And I don't blame them at all because in their heart of hearts, they believe that what they're doing is justified and reasonable. And so if we ask somebody to do an exposure around that, they're not going to want to do it because they believe it's true. It's part of who they are, their personality and identity. So that's why it's really important. And where I've seen OCD specialists struggle is they're going to get resistance. They're like, what's unique about this? And then as we kind of dive into it, it's because they have the OCPD profile and the therapist is trying to get them to do exposures right away with the things that are important to them. So I'd say treatment is a little bit different. So there's something called radically open DBT that helps with personalities of over control. So that's really good with the OCPD profile. I also love just starting out with helping them understand the physical tension in their body, when they hold their breath, all of these different things that occur within the physical body. They tend to be pretty detached from that human experience because their brain is giving all these to-do messages. So I find a lot of value in kind of somatic work there. There's a lot of value in DBT type regulation skills. And then there's a lot of value in CBT, traditional CBT, acceptance and commitment therapy, and some exposure work. But it's not anything where I would necessarily start out with exposure work because it's not going to make sense. Why would I ask somebody to not stay till 10 p.m. at their work if it makes sense to them to stay at 10 p.m.? The true healing comes when those individuals realize that even though my brain is telling me to do these things, is it really bringing me the joy that I'm wanting? Is it causing a toll on my relationships? Is it costing me a relationship with my kids? Like, what is the outcome of these things? Even though I believe that I should be doing these things, is it really helping my depression? I'm helping them buy in that way and seeing the big picture because they're seeing, a very narrow lens of things where we need to widen it and see how everything is affected.
That is so incredibly interesting. It's interesting how it affects other people. Is the pressure that these people put on others the same that they're putting on themselves? Is that sort of where this is coming from?
I think that could be, an accurate statement. And they've likely grown up in a household that's been very similar. So when I've treated this, it's a very generational pattern. And so I'm seeing that affect the environment even more than if somebody would, just meet the criteria for OCD. If we're looking at it that way, I'm spending a lot more time understanding that family dynamic. I've had people say, I didn't want to be my dad or I didn't want to be my mom, and now I'm them. I feel that I've incorporated all these characteristics that I did not like about my parent. So there's actually a lot of meaningful work that happens in that space.
Wow. That's really interesting. So is that more environmental compared to true OCD?
I think it can be a little bit of both, where we're seeing likely a genetic link, but I also see a big piece of it in environmental as well. A lot of times there's an overlap with OCD and OCPD with layers of, disordered eating, with eating disorders, all of those over control kind of personalities. It's not uncommon for multiple family members to be struggling with similar things.
Right. That's really interesting. It's a really good empathy builder, I think, because I have a team here that I work with, and they're super phenomenal. And I had a team member reach out to me a couple months ago, and they were like, hey, this person keeps messaging me on Saturday afternoon and being like, hey, can we do this, that, this? Please let me know by the end of the day. And I don't obviously work on Saturdays. And what we ended up discussing is just, bad boundaries create bad boundaries, right? Is that pressure from that person goes to you, which goes to me, which just keeps perpetuating. So you have to have a really strong and kind, but a strong, I'm sorry, I could follow up with you on Monday. But it's insightful, and I think it brings some empathy, probably is the best word, to just know that it's not coming from a bad place. It's coming from a sort of a misguided interpretation of priority and anxiety response.
And if we look at it through the lens of the sense of urgency.
Right.
And so their brain is giving them a sense of urgency. And I'm going to anticipate, I'm going to send this out. I want a response by 5 p.m. part of the work is understanding that life doesn't work that way. And we have to be building cognitive flexibility. One of the things that's so hard for these folks is kind of going with the flow, going on vacation and not taking work. All of those things, living that life of flexibility in the unknown is so hard. So that's kind of where the exposures are more geared to, where instead of bringing the computer on the beach, what if we just went to the beach with our kids on Saturday instead? And so you're really curious with them. You're helping them kind of build experiments. Like, I'm really curious if you did this. I'm wondering what could be beneficial about you not taking your laptop to the beach and spending time with your kids. You have to help them understand that there would be a benefit in the long run of changing some of these behaviors that are keeping them stuck.
That's really interesting. One of the things that I think is interesting about the brain and how it responds to problems is our brains do hyperfixate, right? Is they say, hey, like, this needs to be addressed now. You're not going to think about anything else until it is. That's where a lot of sort of like ruminating anxiety becomes so debilitating. It's why certain existentials or irrational anxiety is so hard to deal with, and might play into OCD as well, as you have a fear that you can't respond to. And so how do you cope with that? It's also really interesting from sort of a evolutionary biology perspective, right? Because one of the things that's interesting in nature is fear responses are rewarded beyond what they're actually useful for. Because if you're a deer and you're eating grass or whatever, and the bush rustles, if you don't do anything, you might be fine and just keep eating, or you might get eaten. Versus if you run every time, well, you are going to be overly anxious, but you're never going to get eaten.
Yeah, we know what the outcome would be.
Right. And so it's rewarding, right? Because it reduces risk. And in some cases, it eliminates risk to zero or close to zero, or at least gives the feeling that you have. But it's not necessarily conducive, especially because as humans, one, we don't deal with tigers in the bushes anymore. And two, as humans, there's a lot more benefit to risk, right? Is we are constantly put in situations where things being risky is a good thing, right? You want to engage, try your best, right? Like stock market, right? Is you can be irrational and you can lose all your money in the stock market, but rational and intentional investing is, I think pretty much everyone would agree, is a good strategy. So risk is okay, and the amount of risk you can stomach can grossly affect your success, right? Is you can't win big if you're not willing to lose big.
Sure.
But finding that balance is, I think, the challenge. And it's really interesting because so when I did my bachelor's, I focused a lot on like big 5 personality characteristics. And it was interesting to see that different personalities basically exist in different places on that spectrum. And it's because different life situations benefit different personalities, right? There are times where a hyper risk avoidant mentality is beneficial, right? And there's times where it's really, really detrimental. And that's where adaptivity comes in and being able to respond to our environment, right? We're not in a post-apocalyptic scenario where hyper risk avoidance is an absolute necessity, right? That's just not the case. So it's really interesting. It's interesting to see how, as is the case with a lot of disorders, it's not just something that only those people experience, right? It's an exacerbation of what everybody experiences, right?
Absolutely. Yeah, I think too, I'm like, if we were teaching people from the start that avoidance is not the answer, like how far could we be? Like, I think that is the most beautiful lesson you could teach a child, right? Like every time something is hard, anytime something is challenging, it doesn't mean we avoid it necessarily. And being able to distinguish between those cues that are reasonable and ones where we should move along. when we work with families, the parents that are the most consistent with our recommendations and following through with no longer accommodating, their kids get better quicker because we only have them a short amount of time. We're trying to teach everything that's in our brains into the parents' brains so they can recreate it and then not need us anymore. And so they have to be willing to feel uncomfortable and continue to reduce those accommodations and allow your child to feel uncomfortable.
That's really interesting. Kids are complicated. They're so cool. I obviously don't have any yet, but one of the things that is interesting about childhood and development and parenthood is when you start, your goal is entirely protective, right? When you have a newborn baby, there's no, well, let's see what he can tolerate, right? It's like, no, he just made it. Like, there's none of that at all. And there's some interesting research suggesting this is maybe why men and women have slightly different personality profiles. Is you have to be very agreeable with children, right? Especially with a newborn. There's no debate that can be had with a newborn about what's going to happen. It's just whatever it needs for the first few months. But as a child develops, right, especially in early years and even more so as they hit, I think, middle school and high school, a really radical prevention and protection focus shifts to a focus on trying to create, I think, a child who's able to withstand, right? Is you don't want a child who's not experienced the world. You want a child who has experienced it and is able to keep experiencing it. The point of childhood is to become an adult.
And if you narrow it down to how do I build confidence in my child's ability to navigate the world?
That's great.
Or even when we work with partners, a lot of times they'll be pretty codependent on each other because one of them has extreme anxiety, where it's like, how do we build confidence in that individual's ability to manage their own uncomfortable emotions? That's the goal, hands down. I want you to feel so strong and confident in your ability. And the only way to get there is to do this work, essentially, and to give up those safety behaviors. But it's through that confidence, and also parents and loved ones, it's not that we're invalidating the experience. We can validate it and say, I understand it's so incredibly hard for you to go to school today and that you're having so many intrusive thoughts. But I know you can handle it. I'll meet you at the car. And so it's being able to communicate that I support you in this journey, but I'm also confident, I won't say but, and I'm confident in your ability to navigate it.
Right.
And so a lot of times when we work with schools too, schools counselors love this because school counselors, they'll tell us that kids are fleeing the classroom all the time when they're anxious, or they have a fear of getting sick, or a fear of vomiting, a fear of all of these different things. And so then they just stay in the school counselor's office. So once they've been through our training, the goal is to keep them in the classroom.
That's awesome. Okay. Final round. Who should find you, and where do we find you?
I think that's a great question. So our website is going to be great. We're revamping our Instagram with a lot of free stuff. So calmocd.com, and then on Instagram and Facebook as well. One of the things that I'm super passionate about is please do not wait until things are really, really, really significant before reaching out. If you're in that state now, that's fine. Please reach out. But if anybody is starting to feel symptoms, even if it's very mild or moderate, get services now because I don't know what our availability is going to be like. And we get countless calls where people are wanting in right away and we don't have room. And so please call right away to learn about treatment options. Because whether it's for single sessions or an IOP level of care, we want to make sure we can help, but please don't wait would be my biggest emphasis.
Awesome. Cool. Thank you so much for coming on today.
Thanks so much.
Yep. Redemption Psychiatry is a private practice located in Central Arizona. We focus on advanced treatments for depression, anxiety, and ADHD, as well as medication management and neurological testing. If you or a loved one is struggling with your mental health and lives in the greater Phoenix area, feel free to give us a call or visit our website today. Thanks.